Hunt, City and State's Albany Bureau Chief, and we have a great panel here this morning, so I want to talk as little as possible myself, kick it off to the panel. I'll briefly introduce him. Next to me is State Senator Kemp Hannon. He's the chair of the Health Committee in the Senate. Next to him, his colleague, Assemblyman Richard Gottfried, chair of the Health Committee in the Assembly. To his left is Jason Helgerson, the Medicaid director of the State Health Department. To his left is Marlene Zarek, the chief financial officer at New York City's Health and Hospitals Corporation. Next to her, Dennis Whalen. He's the president of the Healthcare Association of New York State. And at the end, last but not least, Jill Ferrillo, the executive director of the New York State Nurses Association. And the bulk of this discussion will focus on this waiver, this time of crisis, this time of transition in healthcare delivery. But to start it off, there's been a couple developments in Albany. Healthcare dominated the end of the session up in Albany. And so, Assemblyman, I wanted you to talk about medical marijuana briefly. You pushed for it for 18 years. It finally passed. Why did it happen this year?
Well, should I use the? I mean, as topics go, it may have very little to do with everything else we're here to talk about, but I think the real question is not why did it happen this year, but why didn't it happen several years ago? And there were numerous points when, in time in the last several years, when it easily could have come to closure, and invariably something fell apart, like the Spitzer administration, that caused things that were about to come to closure to not. But given that we were finally accumulating a significant handful of Republican state senators who were voting for the bill, and in some cases sponsoring it, public opinion polls of above 85% public support, Senator Diane Savino, the Senate sponsor, and I were pretty hopeful that we would be able to get a bill passed in both houses this spring and send it on to the governor and see what he had to say about it. Kind of to our surprise, a couple of weeks before the session ended, we got a call from the governor's office wanting us to come in and talk about the bill. We had been pestering them for a couple of years to have such a meeting, and it finally happened. And once that happened, I think coming to closure and getting a bill passed was almost a given, and it did come to pass. I think it's going to provide important, humane relief to tens of thousands of really seriously ill people. It's going to save a lot of lives in some cases. There are serious restrictions in the bill that I hope we can undo. For example, the bill only authorizes 5 companies to be licensed to produce marijuana, medical marijuana. It requires that the dispensing be done by those producing companies, which is about the only place in the American economy where I can think of where we not only tolerate vertical integration, which we usually don't, but are mandating it, which I think is almost unheard of, and I don't think a good idea. There are a variety of things that I hope we can fix in the bill. To bring it a little maybe closer to some of our major topics of the morning, I think the history of the legislation down to the end is indicative of how, however enlightened we may think we are, our public policy is often dominated by some pretty archaic thinking, which is, I guess, one of the more euphemistic terms I could use. And also how, again, despite what many of us may think, an awful lot of people in government just can't resist telling physicians what to do and what not to do.
And Senator, you are not such a big fan of medical marijuana, but there were other big things that got done. One of them is heroin. Obviously, there was a medical marijuana bill. What was your biggest takeaway in terms of health-oriented legislation this session?
Yeah, I'm going to leave the debate on marijuana to what I said on the floor and let it go at that. I did vote against it, but there's so many other things that were done, and I wanted to touch upon some of the specifics of the legislation and then go recall some of the things that are happening in the health department. We did, just by mentioning by name, readopted the EPIC program for seniors, did a little bit in regard to regulating e-cigarettes, continued with the mandatory offer to take a Hep C test, introduced a large number of initiatives on Lyme disease for the purpose of getting the state to adopt a action plan such as they've done for West Nile on Lyme disease. If you're in any of the hotspot regions of this state for ticks, it becomes the topic of every conversation you have, from gathering at kindergarten to cocktail parties. And we're also able to address some of the regulations in regard to the Office for Professional Conduct. The heroin task force, an incredible epidemic. Senator Boyle had 18 hearings throughout the state, the last one on an Indian reservation in Chautauqua County. It's as bad there as it is in Suffolk County. And some of the things we have done will address it. However, the major problem on that remains we don't have an answer as to how we deal with someone getting off of a heroin addiction. It's a real problem, and it will remain a constant challenge for us as we go forward. We also did safe patient handling, which had taken a number of years for changes in the way that patients will be handled both in hospitals and in nursing homes. You'll hear a lot about the obvious thing that's keeping our attention, which is the DSRIP and CMS, but it's all part of what the state has done, and I want to call attention to these two things. The State Health Improvement Plan. It's an overarching plan for all of healthcare in the state, promulgated last year. DSRIP is actually part of that, but when you think about it, DSRIP is mainly for Medicaid. The State Health Improvement Plan is for all. There's also, as part of the State Health Improvement Plan, a very vigorous prevention agenda, and the rollout of that is encouraged because each hospital has to adopt 2 planks from the prevention agenda as part of their annual community plan. So those are major things that are going on that, as terms of philosophy, everybody ought to be aware of. We continue with what was spearheaded by Jason Helgerson with the Medicaid redesign team and moving so much of our health care into managed care. We have managed care for the dual eligibles, called FIDA. We have managed care for those people with developmental disabilities. We have managed care for people with behavioral health problems. And we actually have on the drawing boards moving nursing home patients into managed care. All of these are daunting tasks, but probably very important for the future of healthcare in the state. We're continuing to work on the electronic side of things, an all-payer database, which was one of the legacies of Commissioner Nirav Shah, working on what is called the Shiny, which will attempt to try to draw together all the regional information exchanges, which will then and those will be dependent on electronic medical records. These are very daunting tasks. And we finally actually did something for people with capital needs. It's part of DSRIP and it's not part of DSRIP. There's 2 parts to this, and that's simply the construction bond money, $1.2 billion. I know that many will say, well, that's hardly enough, but it's a start, and it's a good commitment by the administration to try to address some of the capital needs throughout the state. So those are bigger pictures, even though, obviously, our attention is drawn to the DSRIP proposal and the waiver.
That's a good transition to our main topic. And Jason, you're the expert on this. When it comes to this federal waiver, as we heard in the introduction, it's not a handout. We heard from the senators some of these acronyms, DSRIP, these other things. Maybe you could walk us through just what are the basics here? How will this play out?
Sure. So, yes, the $8 billion Medicaid waiver is obviously a major focus of what we're doing at the health department, and I know it's drawn a lot of attention from providers and other interested stakeholders from across the state. It's really a unique opportunity for New York State to really address some of the fundamental challenges that face our healthcare delivery system and really our impediments to achieving the sort of triple aim of really improving care, improving health, and actually lowering costs on a per person basis. And that's what we've been about since the beginning of Medicaid redesign. And we've worked for over 2 years to get to federal approval. And it's really an exciting opportunity now for us to move forward. And the largest portion of that $8 billion waiver is DSRIP, or the Delivery System Reform Incentive Payment Program. It's not our acronym, it's the federal government's acronym. But we're not the first state to implement this kind of initiative, but our version of it actually is quite different. Our version really is driven by this idea, and I think I'll go back to Pam's opening comments, and the idea is really to try to create more of a team concept in healthcare delivery. It's really trying to create, and you'll hear these words, collaboration, integration, and team as sort of the fundamental concept here, which is we're trying to create what we call performing provider systems. And these are groups of providers coming together in common cause to better serve the needs of the Medicaid population. And when we talk about provider, we define that very broadly. It is providers from everything from your classic sort of hospital provider all the way down to supportive housing or other sort of non-healthcare providers who provide social services that are really essential, that if you are serious about addressing the social determinants of health, you need to include those providers, those organizations as part and parcel of your team to address the needs of the Medicaid population. So this, in terms of understanding DSRIP, I always say there's sort of 5 sort of key themes to the program. And I always say when I'm talking to an audience, is that when folks walk out of the room, I hope you walk out with these 5 things. And sort of theme number 1 is collaboration. It really is about providers coming together, seeing the population they serve differently, seeing how they can work together as a cohesive unit to better meet the needs of the Medicaid population. And no single provider, in our view, can really address the core challenges of the Medicaid population. No single provider is positioned to actually achieve the goals of DSRIP, which at its core is a 25% reduction in avoidable hospital use. And that's sort of the primary measures of under the program. So collaboration is key. Second is, what drives money in the program? It's a $6.9 billion enterprise over the next 5 years. So how do funds flow to these collaborations or these performing provider systems? There's really 3 things that drive it. First off is the willingness of that group of providers to transform how they deliver care. The more transformative you are, the more money you will receive. A list of projects you can select from. Some of those projects have higher value in the sense that they're seen as more transformative. So the more ambitious you are, the more money you would receive. Second is, how many Medicaid members do you serve? And that's a key point, which is it's important for providers to look across their community and figure out who actually serves the Medicaid population. And you need to partner with those organizations because that is what's going to help ensure that you drive up the attribution, as we call it, from a value standpoint. And so in essence, the more Medicaid members you serve, the more providers who serve that population that are part and parcel of your performing provider system, the more money you'd receive. And then lastly is the quality of the application you submit. If you submit a high-quality application that really reflects the fact that you understand the needs of your community, you've done a comprehensive community needs assessment, you've engaged the community, you've engaged your workforce in designing what that strategy is, then you will receive more points and hence more money. So it's important that you take the application very, very seriously. But next is performance. Each and every payment in this program, and I want to emphasize this, is linked to a milestone. It's linked to a performance target. In the beginning years, it's performance targets that are more based on your actual implementation of your reform strategies. So they're process-type measures. So first payment based on, did you get an application approved to participate in the program? But as you transition through the waiver period, more and more the money will actually be linked to, did you actually reduce avoidable hospital use? And that's very different than any of the waiver programs we've had in the past. There's real serious accountability. If you don't achieve those metrics, you don't get paid. There's no payment for effort. There's no payment for being properly motivated or trying really hard or incurring costs. That's not what this is about. This is about achieving results. And I think everyone needs to go into that with their eyes wide open because that's how the money's going to flow, and the federal government is very serious about that. Next is statewide performance matters. We are the first state to operate this program where we actually will have a statewide report card. If we fail that report card, all the performing provider systems in the state will see reductions in the amount of money they receive. And what that means is that what happens in the Bronx matters in Binghamton and vice versa. So we collectively as a state have to rally around this program and find ways to help all the communities achieve results. It doesn't matter if your performing provider system it hits every single metric and does everything it possibly could do to be successful. If the PPS next door or the PPS in another community are failing, that has consequences to you as well. And so it's important for us to embrace that concept and think about what we can do collectively to sort of rise all boats. And then lastly, this is about permanent, fundamental restructuring of how healthcare is delivered in New York State. The idea here is these performing provider systems are not sort of a 5-year and done type exercise. In essence, we hope that they emerge, in essence, almost as a new provider type. Sometimes you hear the words accountable care organization, which we're supportive of accountable care organizations, but we think that that is almost too sort of medical centric of a concept for what needs to happen with the Medicaid population. What we hope these performing provider systems are is a much broader collaboration, and that at the end of the day, they will be able to receive payment from these managed care organizations that is much different than the sort of traditional fee-for-service or sort of I call volume-based payment systems, where the more services you provide, the more you get, regardless of whether or not patients get better or whether or not the overall health of a community improves. These performing provider systems are going to be paid based on value. Did they actually improve health? Did they actually provide high-quality services? Do the people that they serve actually think they did a good job? Was there high customer satisfaction? Those are all going to be the way that payments are going to be made in the future. Vastly different than what we see today. But the last point is, and this is especially important to emphasize here and across the bridge in Brooklyn, but there are other communities across the state where this is also true, is we have some very challenged safety net providers. We must come out of the waiver period with a stable healthcare delivery system. We cannot go from crisis to crisis to crisis. The health department is running out of vehicles to keep struggling hospitals and other providers open. We have gotten to a point now where this is the solution. We must find some way somehow to make sure that these dollars are used in ways that ensure sustainability well into the future. That is not going to be easy. It is going to be hard, but we at the Health Department stand ready to work with all of you. This is not about Albany applying a solution to communities across the state. It's about communities coming together and using the tools that the program presents to actually get to those ultimate goals of sustainability, improved outcomes for the Medicaid population. So that's really what it's about. We're excited. We think it's a tremendous opportunity. It's a once-in-a-lifetime opportunity to really put seed capital into transformation. After a couple of years of actually trying to restrain spending in the Medicaid program, it's nice to actually have somewhat of a change in approach to talk about making targeted investments. But we have a lot of challenges in healthcare delivery, but I think this is really our opportunity to address those challenges.
Now, one factor here is the interdependency, all these hospitals sort of in it together to deal with this issue. And Marlene, the New York City Health and Hospitals Corporation is a key player. Capital New York reported recently that New York City's 5 public hospitals will provide this $6 billion.
No, he means the state's 5 public hospital systems.
The systems, right. We'll have to provide this money up front, and this could be an issue for HHC. You're fairly large, but you have cash flow issues. How will you deal with these immediate challenges, and what is the pathway going forward?
So in terms of the cash flow issues, we've been working very closely with Jason and his staff, and we just, in fact, processed the first, is it okay to
Yes.
the first interim access assurance fund payment. And what we had to do was we had to sit down together and say, on June 12th, this is going to happen, and then 3 days later, this other thing's going to happen, and so on and so forth, so that we were able to avoid any of those problems that the reporter cited.
And tell me a little bit more about your organization's role. It plays a fairly large role in this transformation process.
So let me address that. So as Pam Breyer was speaking, I was actually going a little bit into my memory of healthcare reform, and I've seen a lot of healthcare reform over, I guess, 1, 2, 3, 4 decades, 3 decades. And I'm younger, yeah. And basically, there are some things that were similar about the other reform, and there's something that's very special and unique about this one. And the things that were similar were the other reform was premised on the notion that if you change the reimbursement, if you change the money, the system would change. And I remember as Pam was talking, I was back at 52 Chambers Street before it was the Department of Education, remembering the first 11-15 waiver planning sessions. And the notion was Medicaid managed care was going to do all kinds of things to change the delivery system. That simply by putting the funding in the hands of a managed care organization, we would suddenly have a lot more outpatient care, and we would be providing better care for the patients. Our Medicaid patients would have access to all kinds of providers they didn't have access to in the past, and the quality of the care would go up, and there would be savings. And at that time, I think, and people are laughing because I know a lot of people in this room who were participating in that effort as well. And at that time, there was a sort of a reaction of, let's just try and preserve what we have. Let's try and figure out how to work around this change. Similarly, we went from having, the state used to set rates in New York, even for commercial payers. Then they went to negotiated rates. Similar. How do we preserve? How do we get transition dollars? I'm looking at Dennis. He would be at the health department then, but the folks at Haney's in Greater New York would be figuring out how do we keep the status quo and survive this change. And I think that was fairly consistent throughout those changes. I don't hear that in this one at all. People are saying, how do we embrace this change? How do we make it work? And I think the ingredients that Jason laid out hit multiple fronts at once in such a way that I'm hearing a level of effort on the provider side. Pam, you're agreeing, yes, that I hadn't heard before. The notion of the collaboration is very powerful. So you asked from the perspective of a public hospital system, we're very excited about it because it's the kind of thing we want to do. But because we live our current reality day to day, we know what our obstacles were to doing that. Some of them have to do with regulations. Some of them have to do with how do you set up a governance structure when you're a public entity with a non-public entity. There's all the kinds of issues that we have to work out. But the notion of collaboration, we believe, is very powerful. It's something we've always wanted to do. And now we have to figure out how to do it. And it's a challenge. So that's one. Secondly, the notion of performance is clearly important. That if you don't perform, you don't get it. You have to achieve the performance goals, and that goes back to collaboration because so do your partners. And how do you influence as a big system? How does, even within HHC, our hospitals have a hard time influencing each other, right? And really functioning as a system, even though we have a lot invested in being a system, but it's a challenge. How do we do it? How do we do that? Help our partners achieve their metrics, and how do we trust that they're going to help us do that? That's a very big issue for us as well. Similarly, we're doing this in a very constrained budget circumstance for us. So unlike Maimonides, we really do have out-year budget problems. That's why you're hearing from the reporter. We have cash flow. Oh, she does too. We have major cash flow issues. So we're taking the state hand in hand, and we're assuming that when they're saying sustainability and all the rest, that they're looking at us, and yes,
You're the biggest Medicaid provider we have, so
Yes.
you must be sustainable. So
yes. So we all have to creatively figure out how to do that, and I think there's going to be a major requirement on our part that we take restructuring very seriously, but I think also that there may need to be further amendments to reimbursement, even after you get to kind of the global payment piece. Now, for our system, a lot of the changes that are being talked about, we've done a lot of that stuff in pieces by ourselves, maybe in silos. So we have an ED care management program where we try and make sure that we prevent unnecessary admissions. We already have that. We have something called Project Red, where we provide patient education to prevent readmissions, to make sure that the aftercare is taken care of. We have a home care agency that tries to make sure that that happens. We're not always successful, but we have a lot of those ingredients. We have primary care, highest level medical home status. We have a health home. So we've been in the business of trying to provide care management, trying to ensure that our emergency departments are not admitting folks when there are other alternatives, trying to make sure that when our patients leave the hospital that they don't need to return. And we've done that piecemeal. We haven't done it pervasively, we haven't done it in collaboration with others, and we haven't done it with a performance incentive sitting there. We've done global payment reimbursement with managed care. We consolidated our Medicaid managed care business into 2 plans, Health First and Metro Plus, the plan that we own. And in both those plans, we've lived with a risk-based contract for 15 years. Having the risk-based contract and getting the physicians to behave as if you have a risk-based contract are 2 different things, and we haven't quite nailed the second. So we have a lot of challenge and a lot of investment to go to achieve the goals of DSHRIP. We are very grateful to the state for having orchestrated this, and very grateful to the federal government for the money, because we want to do all those things. We're very, very, very eager to see access to behavioral health services improve, access to primary care improve, access to palliative care improve. We have no skin in the game in maintaining the current system as it is. Our entire reason for being, and I've been in the public sector my entire career, is simply to help our populations stay healthy and be healthy. And we are embracing the notion that this is population-based and collaborative. And I personally am very heartened by the idea that planning, I'm a graduate of an urban planning program, that planning is actually it's actually part of this effort, because none of the other efforts included that.
Sure. Thank you. And Dennis, I wanted to follow up with you on this. Jason mentioned this 25% goal, 25% reduction in avoidable hospital use. I think that's over a 5-year period. Why haven't hospitals been able to do this sort of work without government intervention? And what do you see as the biggest challenges to overcome in reaching those goals?
Yeah. In fact, inpatient volume is down all across the state. So as Pam said, hospitals everywhere are seeing close to double-digit drop in their inpatient services. Now, that's different than, a targeted effort that is focused on reducing avoidable inpatient hospitalizations, because that's about primary care and other structures that need to be built. I was reflecting on Marlene's comments and Pam's comments earlier, where it's easy to find lots of institutions across the state who are, doing great things, embracing this idea of change and trying to build value. Because that's really what about this larger transformation is, right? It's about getting value for patients. It's about getting value for communities. It's about getting value for populations. And people talk about that in different ways, whether it's the triple aim or other kinds of things. The challenge is that we've got change taking place at a number of levels. Certainly the ACA at the federal level has been a driver of some of this change. I continue to believe, though, the federal government is somewhat stymied in these efforts just because of the inability, because of the political and partisanship in Congress. And so I think states become the more active experimenter with trying to get value out of the healthcare system. And I think New York's waiver is an example first of that. The state's stepping in and deciding it's important to do this. Massachusetts is another example. So Senator Hannan mentioned the state health innovation plan. And if you look at that, a lot of similarities between what that is about and what Massachusetts is doing, albeit in a more public, stakeholder involved sort of process. And then we have a bunch of changes that are being driven by technology, by patients being empowered with information that's available. So hospitals are feeling all of this change. And, I'd say largely most are embracing that and trying to figure out a way to get to a better place. HHC and Maimonides, since they're here, 2 good examples of that. HHC with the initiatives that Marlene outside, Maimonides where, before there was a DSRIP project, lots of connections into the community about trying to build these holistic sets of services that deal with social determinants of health and other things. So the problem, though, is that we have a legacy system, right? It's like switching to some new computer. What are you going to do? Because you've got all this infrastructure that already exists, that's built up over time and many years, had investments. If we decided today that we were going to design a healthcare system to take care not only of Medicaid beneficiaries, but of population health needs, we would never design what we have now. You know, we're sort of facing the problem that here's what we have, how do we get to someplace else? And so I think for hospitals, the waiver is an opportunity to transform, right? State had, you know, when governor came into office, had a pretty significant budget deficit. We had the MRT process that reduced Medicaid expenses, improved services under the Medicaid program, but it was clear the state's not going to come up with some big sets of dollars for this transformation. So in the absence of that, you know, the waiver from its first iteration a couple years ago when the state went forward to the feds and asked for that, was seen by healthcare providers as sort of the opportunity to get resources to transform. Now, it also provides a good framework because we're talking about doing things, as Jason noted, in this collaborative manner. How do we build services so they're not siloed under an acute care label, but that really, you know, cover both social and medical and other needs. And so there's great promise there. You know, the potential worries always are, you know, is that what's going to happen over the 5-year period? I mean, things change. We can all identify sort of revolutionary developments that sputtered out because a different idea came along or some problem in implementation occurred. But I do think this provides a valuable pathway that providers are looking to help them get to a transformed state.
Sure, and part of the backdrop here, obviously, is hospital closures. Jason mentioned getting away from this crisis to crisis to crisis mode. When the governor announced this deal with the federal government, this Medicaid waiver, he and Mayor Bill de Blasio talked about hospital closures and how this could maybe address that problem. Jill, you've been paying attention to this issue. Do you see this as a solution to this spate of hospital closures or near closures?
Well, first of all, I think that with the crisis with hospital closures that we've seen is directly related to the system that we have right now in New York. And it is a profit-driven system. It is a system based upon the market. And so as long as we have this market-driven healthcare, we're going to continue to see these crises because what you have are the large systems that are chasing after the high-end insurance patient, and until we got this disparate money, leaving many communities behind. And so that's what was leading to the hospital closure crisis because basically the hospitals serving people who are medically underserved didn't have the appropriate funding, haven't had the appropriate funding, which led to an uprising on the part of communities as well as healthcare workers, nurses, 1199 caregivers, etc. So we certainly were advocating for the disparate money. We believe that we needed the Medicaid waiver money, and we feel passionately that that money needs to go to providers who actually are caring for Medicaid patients. And certainly those who have traditionally been caring for Medicaid patients have the experience in doing so, and we believe that that money needs, for example, we're talking about HHC. HHC has that experience. Now, when we look at the issues surrounding the disparate money and the goals stated for that money, we have to really look at the crisis in New York and see that what's driving that crisis is poverty. We have over 46% of people in New York still living in poverty, in or near poverty. And so what we have are poverty-related diseases that, we are talking about people who need care, and some people need more care than others based upon the history of those poverty-related diseases. So what we don't want to see is the health care that exists right now for those communities just be completely wiped out without making sure that we have the appropriate systems in place to care for those people. And when we talk about the targets that is set forward by the district money, we have to make sure that those people are not being left behind. We don't want to eliminate what they have and then have nothing in its place. And I can give you the example of Bedford-Stuyvesant, where we had the closure of St. Mary's Hospital. They had an incredible primary care network with all kinds of clinic care, primary care. And what happens when that hospital closed? The clinics closed too, and the percentage of people who get primary care in many of these communities get that through the acute care facilities. So there has to be a transition in place, and we have to make sure that we're talking about care of patients. Patients are people. These are not just targets. Patients are not profit set. I mean, the industry looks at people as profit centers or patients as profit centers, but we have to look at them as people and people who need care. And then we have to look at outcomes. Patient outcomes is what should be driving what our system is all about. That's not what's happening in New York right now, and that's why you're seeing the uprising, throughout New York, especially in the communities that are being left behind.
Sure, and I'd like to open that topic up to the panel as a whole, this hospital closure topic. Last fall, Stephen Berger, he was the head of the Berger Commission, wrote this piece in the New York Post. He said, "It's painful to see a hospital close its doors for good. Painful for patients, painful for workers, painful for the community it has long proudly served. But that pain and the public outcry that always accompanies a hospital closure doesn't change the fact that sometimes hospitals simply reach a point where survival is no longer financially tenable and their services are no longer essential." So in this context of transition, with this waiver potentially, what is the role in terms of hospital closures? Will it save hospitals? Will it result in more closures? What do we expect here?
Sure. So what we need is a delivery system that's patient-centered. This has to be less about the provider and more about the patient. And I think that's historically been, the system in New York State has, in the conversation about healthcare, has been more about providers and less about the patient served. That said, as we think about what that future delivery system is, we need, and that's what's unique about the waiver, is it's potentially funds that allow us to transition from the system we have to the system we need. And that transformed system is going to look different than what it is today. And it definitely is going to mean there's going to be less reliance on inpatient utilization. And frankly, regardless of whether we do the waiver or not, this future system, and has been pointed out, there's been a reduction not only in New York, but across the entire country, and I would argue probably in most developed countries across the world, of an actual reduction in the reliance on inpatient care. As the science has advanced, as the technology has advanced, there is more and more that can be done in settings other than an inpatient setting, and done in a safer, better way for patients. And so that's just a general trend that's happening, and that trend's going to happen regardless of whether we do the waiver or not. But what the waiver does is it gives us an opportunity to ensure that communities continue to be served. And in fact, why it's so important to do the community needs assessment is to figure out what the community actually needs from a healthcare delivery standpoint, and then design solutions that get us to that system. It does not happen overnight. As Dennis points out, if we were to take a step back and say, okay, let's redesign the system and rebuild an entirely new delivery system today to meet the needs of New York City residents, it would look very different than what it does today. But we still have that legacy system. And so the question is, how do we get from here to there? And it's not easy, but the waiver is that unique opportunity. The waiver is actually more than just the $6.9 billion in DSRIP. It's also $1.2 billion in capital, which, as pointed out, not all the money that might be needed, but certainly hopefully it can be a leverage as a resource. Also, it's regulatory relief to allow for integration of services in a more effective fashion and much faster than has been the case. Part of the problem we have is that we have a regulatory system that reflects 20th century priorities and a very siloed system driven to a great extent by state policy of multiple state agencies, each regulating different types of providers in a very siloed fashion. Makes it very difficult for providers in a timely fashion to do the things that patients need in a much more patient-centered fashion. So I think bringing all those tools together gives us a unique opportunity. But is it going to be easy? Is it going to mean that there's going to be challenges along the way? Absolutely. But I think we have no choice. And I think we have to find a way to ensure that that future delivery system really matches the needs of the population.
couple of things I have not heard about in a lot of this discussion. One is a major element of our healthcare system, not surprisingly, is who is in charge of paying. You know, the old saying, the one who pays the piper calls the tune. I don't think we're doing much in all of this work to deal with the fact that the payer in our society for an awful lot of health coverage, more and more health coverage than ever, is insurance companies. And whatever you may think about the public spiritedness of hospitals or the health department or any of the other entities we've heard talked about here today, any insurance company that guided itself by what is good for its patients would be illegally disregarding its duty to its stockholders. And as long as we are structuring a system, however we rearrange relationships among providers, as long as at the end of the day it is a system in which what gets paid for and to who is determined by an insurance company, whether they are a Medicare managed care company or a Medicaid managed care company or a plain old managed care company, they're still an insurance company. And increasingly, we are turning over virtually the entire Medicaid program to insurance companies and stepping back from the state having a regulatory role. The starvation of the state administrative and regulatory apparatus proceeds apace, and I don't think the Medicaid waiver is going to enable us to pay state regulatory or administrative staff. And we've heard about planning being back. There are people planning things, but a world in which there is no hearing that people from the community can go to and say we're in favor of this and we're not in favor of that, which at least in New York City is part of our land use planning system, and across the state used to be part of our health planning system when we used to have one. I don't see that coming back. And so there is a lot that I think we still need to address in this agenda.
Well, Dennis, I think you had a comment in response to what Jason was saying, maybe in response to the Assemblyman as well.
Sure, a few things. First is I want to slightly disagree with Jill and then agree with her on another point. If you go to any hospital, I don't think you will see hospitals viewing patients as profit centers. Because you can easily identify in any hospital services that get provided, individuals that get treatment, communities that get served, which in fact increase a hospital's challenge financially. It is true hospitals worry about reimbursement and cost because that enables them to deliver services. But I think her point about, you cannot abandon healthcare needs when you're looking at these situations of hospitals closing. And again, if we designed a healthcare system to treat the needs of any community, I think it would look different than we have now. Now, more recently, the state has been engaged in, looking at freestanding emergency departments, duly licensing various primary care entities and other things. And I think those are good efforts. But I think Dick touched on a point that I think is going to be a continuing challenge throughout the life of this waiver. And that is the ability of the state to keep pace with the amount of change that's taking place. Look how long it took to get a freestanding ED approved. Now, is a freestanding ED a good thing? Does that serve the needs of the community? In and of itself, it does not. I mean, you need a whole array of services that look at the healthcare needs, based on an assessment of the health status and needs of that community, and designing a whole set of services that do that. And I think that's what's been missing, is that sort of comprehensive view. Now, will that be able to be funded under the waiver? Will we have enough regulatory flexibility to get there as a result of Jason, talking about siloed regulatory programs and other things? I think that's going to be a continuing challenge that we'll have to push against. And, 5 years is a long time in a government program. And look, I spent 35 years in state government, and so I know one of the things that government does least well is sort of continually assess and reassess and make adjustments along the way. And that is critical to success in this endeavor of trying to build value into the health system as we go forward.
Marlene?
I wanted to address Dick's point, but also in another context, which we haven't talked about yet. There's a lot of other things changing from the Affordable Care Act that is also affecting the mix here, particularly in the Medicare program. So providers are starting to really focus on the value-based purchasing aspect in the Medicare program. And in a very new way, they're being forced to address patient satisfaction, not just quality. Quality is, you could provide good quality and the customer satisfaction is poor because you're either rude or you wait a long time or things like that. And now that's been embedded in the change agenda for providers. So I think that it's a very powerful change agenda. And I want to now agree with the Assemblyman that the insurance companies need to be brought along as well. And I agree with Dennis that the processes, the regulations, the procedures that are regulated by the state also need to be brought along as well, because the delivery system doesn't exist in a vacuum. And so those are the insurers and the regulators are the really important levers. If they hold on to the risk-averse nature the government has, where we're going to regulate things in a certain way, you won't be able to change. You will get stopped. So we have an important project. It sounds great. We need to co-locate primary care in the emergency department. Folks are waiting in the emergency department when really they need primary care. There's a whole morass of rules and regulations that make that very difficult. So we can talk about what we want to do to change. We have our habits. We have our infrastructure. We're legacy systems. But we're going to need our regulators to be flexible to help us change. In addition, the insurance companies can't be out of this. They have to be part of this. And I would welcome hearing how we could possibly do that, or if the Assemblyman has any suggestions on how, or if anyone does.
As I often say, I have a bill.
I knew it.
The insurance companies will always hire more and probably smarter lawyers than the rest of us will be able to hire. And we in the legislature have tried regulating them every which way. And you know what? At the end of the day, it doesn't work. And the only way to bring insurance companies along that will be productive is to bring them along to the door and say goodbye to them. If care coordinating is supposed to be done by providers, which I would like to see happen,
Right. What do you need insurance companies?
at what point do we can't we ask, what do we need the insurance companies for? And I think the answer is we don't need them for anything, and as long as they are paying the piper, they will call the tune. And you can try as many ways as you want, as long as they pay the piper, they will call the tune. And if you wonder why Medicaid managed care didn't solve all our problems, and why any number of things haven't solved our problems, I think a key element of that, I mean, yes, there are many elements. Changing entrenched provider attitudes is difficult to do. All kinds of things are difficult to do. But as long as you build in such a central role for non-governmental private corporate payers, I don't see how you succeed.
And I wanted to ask the senator for a comment, and then we'll go to Joe.
The reason we can't get rid of insurance companies is that there's a certain thing called risk, there's a certain thing called reserving, there's a certain thing called payment, and as much as, and by the way, they're certainly not, great reputation, but that's what's happening. And we are also deluding ourselves if you think you can change it. The entire structure of Obamacare is based on insurance companies. So instead of changing the paradigm, it's adopted it. Now, some people have jumped a little bit over the wall. North Shore LIJ, 16 hospitals, also formed its own insurance company, and they're on the exchange. Whether that will be a mind changer or not, I don't know. We've seen in the past, New York Hospital had its own plan when it was New York Hospital. So, there are experiments. You've worked yourself on the ACOs, and they try to cut out insurance companies in a sense by having the providers be managing their own reward and delivery of service. But on the other hand, the ACOs that have worked well have been the huge doctor practices working with insurance companies. So that these contradictions exist, and you just can't make the simple conclusion that doing away with insurance companies will solve anything.
And then on to Jill, and then I'll ask Jason one more question, and then we'll go to questions from the audience at that point. So if you have any good questions, think of them, formulate them.
Well, just on the issue of insurance companies, the New York State spends approximately $9,000 per patient a year on health care. That adds up to about $180 billion. And this year it'll even be more than that. It'll be up to $200 billion. So it seems like there's enough money in the system to be able to give equal access to care and give quality care to everyone. But we do have this problem of about where that money is going, and that money is not going to the direct care of the patient. Now, it is our view that when we strongly support the Gottfried bill, because it does address that issue. You're talking here about the reduction of inpatient beds, but we're not actually seeing that play out in an equal way in New York. For example, we have 2 beds for every 1,000 people in Brooklyn. We even have less than 2 beds for every 1,000 people in Queens. But on the Upper East Side of Manhattan, there are 15 beds for every 1,000 people on the Upper East Side, and they're continuing to build even more and add even more there. So what we're not seeing is truly equal access to care and, frankly, equal reduction in inpatient care, depending on who the population is that's being served. So from our perspective, that's not right, and that needs to change. So we need to have a system that's based upon care for all folks. And I think that what we've seen with the insurance plans under the Affordable Care Act, I just read an article yesterday. People bought these insurance plans because they had to buy these insurance plans to have the access. Some folks felt that they were affordable. And then there was an article yesterday about these insurance plans now saying they're going to raise their rates by 8%. So is that going to really solve the problem of access to care? And so I think that when we see this play out, we have to even continue to look at the Gottfried bill as the solution here in New York. Thank you.
And getting back to the Medicaid waiver a little bit, Jason, I wanted to ask you to follow up on Marlene's comment about regulations and sort of regulatory flexibility. What do you anticipate there? And then secondly, maybe you already touched on this, but to what degree is this a prescriptive approach, or to what degree can systems come up with their own solutions to meet these benchmarks?
Sure. So first off, on regulatory relief, Marlene, her example is perfect, which is we make it amazingly difficult for people to do what all of the research suggests is the best way to provide care to people, particularly to low-income populations, and to provide care in that integrated fashion. And there are multiple processes that could take years to get through all the approval stages in order to do what it is we say we want them to do in terms of improving care and outcomes. We, the state, fundamentally have to change how we operate in order for this to be successful. That's why the regulatory relief option through DSRIP that the legislature approved is so essential. Now, we are prohibited in any way, shape, or form from waiving regulations that would have any impact on patient safety. But we, as not just the health department, but our colleagues at OMH and OASIS and OPWDD, we all have to take a step back and look at ourselves to say, what is it that what do we really need to have our eye on from a regulation standpoint? And that really should be patient safety. And we should get out of the way when providers are doing innovative things consistent with improving patient outcomes. If we don't do that, we're going to create a logjam where people are not going to be able to get the approvals necessary to be able to put the programs in place to achieve the metrics. And as a result, money will be left on the table as part of this waiver, because as I say, it is all about performance. So it's really essential that we make that the case. And then your second question, are we imposing a solution from Albany on New York City or on anywhere else in the state? And the answer to that is no. Yes, there are requirements in the program. Those were negotiated with the federal government. The federal government itself has very strong interests. This is their money, and they want to see it spent wisely. They have been very clear. This is the last waiver they have any interest in approving of this type for New York State. This is as I say, a once-in-a-lifetime opportunity. We have got to make this work. And yes, they have put more accountability into this than any other waiver, not only they've done for New York State, but any they've done in the country. And I honestly, looking back on HEAL and some of the others, can't honestly blame them, because I think we had some missed opportunities there. And I think the reason we didn't have missed opportunities was, frankly, the federal government didn't push the state hard enough to put that accountability in. And if you just look at the language that the federal government has required us to sign off on, the terms and conditions and the other governing documents, and you compare that, it's like 200 pages of detail, and you compare that to the paragraphs that were included in the waiver for the HEAL program, it blows you away in terms of the amount of accountability that's in there. But that said, I think what it does give is a series of tools and an opportunity for communities and providers to fundamentally look at the needs of their community and design solutions that meet those needs. The more effective they are at identifying those needs, engaging the community, the only thing I would say, is there are requirements in there that they actually hold public hearings in their communities to get that input. That is an absolute requirement. And the more effectively you can demonstrate you engage the community, the more money you will get. And that's, a key part of this. It has to be a community-based solution. Yes, you can't choose, there's, almost 30 projects you can select from. You can't just do anything you want. There's some requirements around consistency, but I think that when you look at those projects, there's plenty of opportunities. There's lots of evidence-based solutions out there, but you need to choose the projects that really reflect the needs of the community and build that solution with significant community input. So.